Okay, so we've already started massaging around the hips a little bit right from our first compression routine and even doing some pin and stretch. But now we're going to dive deeper into the anatomy and physiology, or excuse me, the kinesiology of it. So I kind of like this picture because it really kind of shows that kind of twisting, rolling kind of bowl-like movement that the hips are capable of doing. So the hips have one of the most mobile joints. I mean, this is the entire pelvis, but right here between the femur and the hip would actually be the ball and socket joint, and we'll come back to that in a minute. But let's first take a look at the basic functions of the hip. You know, that bowl-like structure allows it to be protective or supportive of the organs inside. I've mentioned before that whenever you put organs inside of bones, you know, that's really indicative of those are really important organs to protect. It also serves as a vital attachment point for the lower limbs. So we go between the axial skeleton here, like axis, down to the peripheral skeleton here. And here's our attachment point at this ball and socket joint, this Acetabulofemoral joint between the femur and the hips. And when I talked about that first massage we were doing, we were all around here. So that deep socket of the hip is actually very deep and you can't get anywhere near touching it. But where we can massage the actual hip part is right around here. So we'll zoom in on that later. This attachment between the axial and the appendicular skeleton, this is a place where we have to be able to support the weight of the body for standing and moving. So we support all our weight, obviously, on our feet and legs. And when we talk about the movements or the relationship of, you know, the structures when they're against a stable surface, kinesiologically, that's called a closed chain. So a kind of challenging and interesting thing about studying the movements of the hip is that we sort of look at them and the actual movement is different if we're looking at the foot off the ground and what kind of movements are capable there, which is called an open chain. But once we put those feet on the ground, that now is a closed chain, and that really changes where most of that movement occurs. So when the feet are planted, we're going to get more of that movement at the pelvis itself. But then once we take those feet, one or, you know, both off, we can get more of that movement up at the hips. And that'll make more sense as we look at more videos and pictures and explore movements and so forth. That concept of closed kinetic chain and open kinetic chain will come up again later. But are there questions so far? All right, so we're going to take a very short poll. Let me cue the poll and give it an introduction. It's sort of a review poll. Part of its review. So I'm going to give you 5-10 minutes here for this poll, but I'm going to read it out loud and also sort of explain it. So the hip joint, this Acetabulofemoral joint, right here is a ball and socket joint. And there's only two ball and socket joints in the body. There's the hip and there's one other, and they allow the most movement. So is the other ball and socket the elbow or the shoulder? And then question number 2, what is the official name of the hip joint right here? That's a ball and socket joint. And it's not an accident that I included the name right up there in number 1 and I keep saying it, because this is about learning, not about tricking you. So ding, 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 the answer's up in number 1 for number 2. So everybody who has responded thus far has got the answers correct. Number 1 is, anybody out loud?
Shoulder.
Thank you. And number 2 is? That's a harder one to say. Is that why people are pausing?
Yes, that's exactly why.
Can't see the word anymore because I sent my phone.
The word, the A word.
The A word. There you go. There you go. Okay, so it's the Acetabulofemoral Joint. Yeah.
Acetabulofemoral Joint.
Perfect. Perfect. Way to be brave and say it. So a lot of these kinesiology words, whether we're looking at a joint or a ligament or a tendon, sometimes they get kind of long and crazy sounding, but when we break them down, they usually have the bony landmark and or bone name as their kind of root of their words, or their prefixes and suffixes and roots. So here you can see the word femoral, and here we have the largest bone in the body is the femur. So we have the femur connecting with the hip, and that socket, we'll look at slides later, happens to be the acetabulum. So that's where we get acetabulofemoral joint. So we're going to have a short breakout room to discuss this next question, and it's really more of a thought experiment. It's not a test, but I want you to think about and discuss. We've got 2 ball and socket joints in the body. We've already established that the hip and the shoulder are our 2 ball and socket joints. Now the ball and socket joint allows the most movement of all joints, but the shoulder joint allows even more movement than the hips, because we want to be able to grasp and manipulate objects with our hands, whereas the hip joints, they need some flexibility, but we also operate in a closed kinetic chain where we need that stability. So can you see the difference of why, even though they're both ball and sockets, the shoulders are going to be even more mobile than the hips from a purpose standpoint?
Yeah,
I see some head nodding. Yeah? Okay, cool. So what I want you to think about, and you can sketch out pictures or flip through your book and talk with your classmates, what I want you to talk about and think about just for like 5 minutes is, what do you think structurally has been, is the design to actually physically make the hip joint more stable than the shoulder joint? So there are multiple design elements that actually make the shoulder more mobile and the hip more stable. So go ahead and think about that. Maybe take some notes, draw some pictures. I'll give you a hint. It's more than just one thing. And you can even look through your book, and we'll discuss that for 5 minutes in breakout rooms. And I'm going to now end the poll also. I wanted to leave enough time for anybody who popped out for a second. You're not going to get points off if you answered wrong. I just want to engage the class and also make sure people stick around. So great job on the poll. And I'm going to share the results. We had 100% were correct about the shoulder, and 92% were correct about the acetabulofemoral joint. Great job. Okay, so are there any questions about what you're going to discuss in the breakout room? Nope. Okay, cool. So I'm going to make your groups kind of big. I don't want, does about, let's see, we have 13 people in here. 4, 4, 3 sound good? Or more like a 6 and 5? Bigger groups, smaller groups?
6 and 5.
6 and 5, bigger groups. Okay, so let me pause our recording.
Yeah, I was talking about how the ball joint for the hip is attached to something as stable as the pelvis versus the shoulder blade, or the scapula, I should say, which is kind of like free floating and just attached by the collarbone. So I thought maybe like where it's anchored is just more structurally sound.
Yeah, I think that's a very interesting point. Yeah, thank you. When we looked at how that entire, upper limb just has this one attachment point. Yeah, thank you. Anything else come up about why structurally the hips are more stable than the shoulders? Well, I'll just quickly recap for the especially the video, anybody who's missing out. Take a look at the skeleton and all the pictures about how deep the acetabulum is. That hip socket is like a bowl, and in the shoulder, it's like this flatter plate. And so the deep bony socket physically keeps the femur from being able to move around or pop out as easily as the shoulder, which dislocates quite easily the shoulder relatively to the hip, which rarely does. So there's literally a bony encasement that adds even more stability and limitation to a more plate-like structure. Does that bring up questions or comments? Okay. So we're going to move on a little bit further and then just watch a little bit of the intro to the dissection video because there's such great three-dimensionality of that. People already called out that there's 3 bones that make up the pelvis. This one is just an artistic of an animal, Georgia O'Keeffe, so we're not going to focus on that one. But if we look at the whole pelvic girdle, both sides fused or with a joint together, we have 2 hip bones, the one on the left and the one on the right. Those coxa are what's made up of the 3 bones, ilium, ischium, and we have the next slide will break that down. We have that big, large triangular bone, the sacrum, and then the little tailbone, the coccyx. And both the sacrum and the coccyx are made up of fused bones. So let's take a look at, I like this color coded, the real bone diagrams are great for seeing the real bones, but I like this colored one because it actually shows you the separation of which part is the ilium, which includes that top where the hips flare, and this whole upper iliac crest is all palpable all the way to the front. And then this is actually a typo here, excuse me. The pubis is this pink part in the middle. This lighter pink part is the pubis. And then the ischium is this darker fuchsia. And you probably, hopefully, have already heard of the ischial tuberosity. This, because we're already massaging around it, is this whole base part, the sits bones, where if you sit with good posture, this part right here, and where the hamstrings attach. So this whole part here is palpable because of that. Are there questions so far? Now, technically, most of this ischium is actually palpable as well, and the adductors attached there. And if you're just, practicing on yourself to feel exactly like how does that go, you can. But we do not massage the adductor origins there, for obvious reasons. It's too vulnerable and too close to the penis and vagina, and so we don't ever massage this area, even though it technically is palpable. But definitely we do massage the ischial tuberosity and then all the way around the iliac crest, and then the ASIS and PSIS, and then on the back of the sacrum. So those are all very palpable. As I mentioned here, this acetabulum, that socket of the hip joint, is really deep to the femur and is not palpable at all. Does that bring up questions about what's palpable or anything about these bony connections or fusions? So as far as this pink and fuchsia and yellow, this is what's fused, the 3 bones that make up each of the os coxa or the hip. But the sacrum and the connection between the 2 hips, those are by joints, not fusions. So there's active joints here between the sacrum and ilium. And it needs to be supported by ligaments, just like any other joint. And I mentioned in one of the breakout rooms that there's actually quite a bit of pelvic instability there for quite a few people, and it tends to be more women. So we'll take a look at that in more advanced hands-on techniques with pelvic stabilization. Since we just did pregnancy massage last week, I think it's a great time for the pelvis to come up. And we talked about how relaxin relaxes the ligaments, and so that we can widen the birth canal for labor. And this is one of those joints right here. It's called the pubic symphysis, where this will actually get softened and loosened enough for that to move open. And sometimes it'll even open completely and need to come back together. But you might have in your practice, because it's not that uncommon, especially if you massage like after motor vehicle accidents. It's not that uncommon for people to have, you probably have heard of people's pelvis shattering. They can have, this separated or breaks in different part of their pelvis. So, questions so far? So the sacroiliac joint, as I mentioned, actually becomes unstable in some people. And I think this diagram's a little misleading, which is one of the reasons why it's really useful to look at 3-dimensional models. So definitely look at your model at home, and then also look at the big models in school, because there's actually a huge surface area of where that sacrum attaches, and you can look at it from behind as well. We've got our acetabulo or hip joint. So I just want to call this out and make it really clear. You can call this joint the hip joint or the coxal joint. And so when people talk about the hips or the hip joint, technically, it's focusing on that acetabulofemoral joint. In common language, just like when people say the shoulder, they could be talking about anything from the scapula to the actual shoulder joint, the whole region. So when people talk about the hips, they could be talking about like the whole region, but specifically of all of these different joints, it's specifically talking about that ball and socket joint. Questions so far? And then we've got our lumbosacral joint, and this is another one that's useful to look at your models to see what that looks like. And he's going to show in the video, which shows you a good, from a good angle with bones cut and removed, what a big angle is right there. So the pelvic girdle articulates with the femur at the acetabulofemoral joint. This is what we've been focusing on so far. And as somebody called out in a breakout room, a great diagram that shows you from the side, we've got all 3 hip bones as part of this socket, but those are fused bones that make up that socket, which is really like a bowl-like structure. So we can see we've got this palpable iliac crest, we've got our ilium on top, we've got our pubic bone in front, and we've got our ischium behind. And then the ischial tuberosity that we sit on is really this whole base part. So our next muscles we're going to come across are our thigh muscles, like our hamstrings. When we see that the hamstrings all attach on the ischial tuberosity, it's really a huge area. So, you know, when you stick your elbow up into the ischial tuberosity to really get those muscle attachments, you can palpate and work around, you know, the entire ischial tuberosity because it's a really big and the whole thing is palpable. Does that bring up questions so far? Okay, so we've talked about that already. Here's a nice close-up of that articulation with some real bones. Kind of interesting, I think, that this this femur, first of all, is like, if you're looking at the correct one, it's like the number 7, and you've got the big shaft of the bone, and then like a wrist, and then the ball. So the femur is this whole like number 7 structure, and this round part here is called the head. So the head is what articulates with the socket. It's like a fist in a hand, is that ball and socket. And you can see on this one that it's just the head that's covered, it's covered with this smooth cartilage, so that the top of it is covered with a cartilage so it can really slip and slide in there. And of course there's slippery fluids injected in there as well. And as soon as we get to the anatomy of the skeletal system, we'll look at the joints in general in more detail with exactly how that works with the synovial fluid and all of that. But one of the things I think is interesting about this is that there's actually a ligament right in the middle of the head to help it go into that socket. Kind of like some dolls, like Barbie dolls, would actually have like a springy connection inside there. There's actually a ligament in there. But the stronger ligaments are actually wrapped all the way around outside, and they're stronger hold than that one there. Here we can see that the acetabulum, that deep, what they call a socket, which is like a bowl, is really a deep bowl to hold that femur. And then, so this is a nice view to see that this is the part that we massage around. So this is all palpable, but of course not this deep part. Questions? So I've been trying to focus on the parts that are palpable for massage, because those are some of the most important aspects for massage therapists. You know, where do the muscles attach? What parts can we massage? But I think it's worth calling out here that, you know, most of these inner structures, you know, we cannot palpate from the anterior side. So we're palpating really around the top and the bottom and the back and the sides. This is all protected deep territory. The only exception is that when we do psoas release or iliopsoas release, there's a little bit around the anterior corner of the bowl of the ilium that we can reach around, just literally where my pointer is. So we cannot get, you know, all the way deep here, but we can get to the part of the muscle that's just around the lip. But that's a rather deep, rather advanced technique, and that's not where we start off, but we will get you there. Questions? Okay, so a couple more bony landmarks. I talked about some of these important palpable ones, but and I mentioned by name, but I really want to call it out on the diagram. If you walk your hands all the way up and around an iliac crest, which is a very important massage attachment place from above or from below, lots of great muscle attachments. You walk away all around to the anterior or front, is the ASIS. And you can do that on yourself right now. I recommend that you do, and also look at your model. And the ASIS is on the front, and it stands for Anterior Superior Iliac Spine. And so that's the front of the ilium, and it is palpable. If we walk our hands all the way around to the back of the iliac crest, which we can do, and I recommend you do explore it on your model and yourself right now, all the way on the back is less prominent, but also palpable, is the PSIS, and that stands for this up here on the upper left, Posterior Superior Iliac Spine. And from a posterior view of the sacrum, let's see if we have one right here handy. Well, this is a nice bony depiction of the PSIS right here. But I want to show you a view with the sacrum. Sorry for the scrolling. Okay, here's a good view. So from the back, if it's articulated, this is the PSIS right here, and it is palpable, but right just medial to it is where the sacroiliac joint is, all along here. And so people who get those little dimples on their lower back, this is where you would see those little dimples. So I just want to call out that this is palpable, but right around here, just right where my pointer is, just medial to the iliac PSIS, is actually tender, not in a way that releases really well. So the whole rest of the lateral border of the sacrum is fantastic for massage. You can really linger and do prolonged ischemic compression. You can do myofascial release. You can do cross-fiber friction. It's all excellent all the rest of the way. But just right there where those little dimples are, it feels really tender and doesn't release really well. So I would say that's actually a bit of an area of caution. It's not that you can't touch it at all, but it responds better to things like broader areas of pressure with some nice MFR stretch, not like a digging in there with a small sharp tool. Does that bring up questions or comments?
Does anything go through the holes in the sacrum? Like, I think that's what you're talking about, right? The dimples on either side of the sacrum?
Yeah, that's a great clarifying question. So there are actually nerves that go through the holes in the sacrum, but those aren't the same as the little dimples. So when you see the little dimples, they're actually just kind of right here, and they're not the same as the holes in the sacrum.
So is that, so is that like the same as when, so like, is that like the same when you have like a dip in your back?
I think so, but I am not sure, because I'm not sure what you mean.
Like, so you know how like some people have like, so the dimples, where the dimples start, it's like a kind of like a dip, like, you know, like it's a like dip.
Sway back?
Yeah, that's what I mean. A sway back, basically. Thank you.
Back. So great clarifying question. So the sway back can be totally separate and unrelated from the dimples. The sway back is can be from an anterior pelvic tilt and the whole lower back having too much curve. So that is really in this whole area, excess curve, and then also the sacrum tilting and the pelvis tilting forward. Whereas the dimples are just little dimples right here. And people don't have to have the dimples for the same palpation thing to be true. Just when you follow the iliac crest and you find this PSIS, I just wouldn't poke deeply with a small sharp tool in there, whether or not you see a dimple, just because of the instability of the sacrum, and also it can be a tender area. But rather, all the way distal from that on the lateral border of the sacrum is a great place to work. Does that bring up clarifying questions? And does that answer the ones people had?
Yes, thank you.
Okay, great, great, great. You're welcome. Okay, so just a couple more quick things, and then I'd like to show you the first 10 minutes of the video, which is the part of it we need to highlight the most. Pardon me for the scrolling. So again, we want to, as massage therapists, focus the most on what is palpable, where the attachments are, and then anything relative to, the conditions our clients tend to experience, like the anterior pelvic tilt is super common. I would venture to say 70% of your clients, female clients, have anterior pelvic tilt. And so, and quite a few people have the pelvic instability. We'll get into the details of which muscles are too short and tight and which fascial patterns are too short and tight in that scenario, and it's going to inform which areas are you going to focus on stretching longer and relaxing because of that situation. But here in anterior pelvic tilt, we would have the angle between this ASIS and PSIS would be a bigger angle. And then that would correspond with that sway back with a bigger angle here. So just a nice side view that, of course, this whole way is palpable and very great to work. I've been saying it, but as we keep doing more specific work and fascial work and trigger point work and deeper work, your palpation skills are going to go to the next level. You've already got a great base on your palpation skills, but you'll really be able to do things like focus your stretching work and fascial work from the torso down to the top of the ilium. And we've been working sideline quite a bit lately, and that's even great sideline because you have some good movement possible from that side position. But then pretty soon we're going to get to the muscles in the glutes and the hips, both the glutes and the deep rotators, and see how important it is to actually work this iliac crest from the glute side as well. So we can focus on different muscles, the glutes, and from focusing on that from this side. Now, this anterior gluteal line, inferior gluteal line, these are very subtle differences right there on the bone, and that you'll see when we study the glutes. Those are the different attachments of the glutes, but those are way too deep to palpate. The glutes are big solid muscles, and you've also got the deep rotators of the hips there. So we can do a lot of specific massage in this area, but you're not going to get all the way down to that subtle line on the bone. You just never would feel it. So that's kind of one of those landmarks that's more about, that's where the attachment is, but that's not, you're not going to massage exactly there. Does that make sense as a distinguishing between palpable and not palpable landmarks?
Yes.
Okay, cool. All right, so a couple ones that are going to come up as far as when we start looking at, what is happening with the sciatic nerve, what's happening with some of the muscles that kind of turn a corner. We have a couple other deep landmarks that we're not actually going to palpate. From the side view, you can see this big, kind of turn in the bone here. This is called the greater sciatic notch. If you have your textbook and your model, I recommend you take a good look at it. And then here we have the lesser sciatic notch. And again, those are deep and not palpable, but you'll see them come up when we study the structures. And there's a couple more, but I think that's the main ones. And I'd like to now go to the video. Yeah. As far as the sacrum, by the way, on the sacrum, we've got this big triangle. There are names of the areas, like the ledge is called the promontory. but you don't need to know the names of everything on the sacrum. But what does come up is that the holes are called the foramina, the sacral foramina. And foramen or foramina is a standard name for a hole. So you'll see foramen or foramen come up other places as well. All right, I'm going to pause the recording.
Here's the pelvic brim. We'll be looking at the pelvic cavity from 4 different viewpoints. We look down into it from above. We'll look at it from the side, with the opposite half of the pelvis removed. We'll look at it from behind, and we'll look at it from below. We looked at the features of the upper part of the bony pelvis in the last section. The bones that contribute to the walls of the pelvic cavity are the sacrum and the coccyx behind, and the lower parts of the hip bone in front and at the side. We're looking at the bones in the position they occupy when we're standing upright. In the upright position, the surface of the upper part of the sacrum is angled at 30 degrees to the horizontal. The tip of the coccyx points forward at about 40.
Okay, can you guys still hear me?
Yes.
Yeah.
Yeah, okay.
In the position they occupy
pause it there for
when
a
we're
second.
standing upright. In the upright position, the surface of the upper part of the sacrum is angled at 30 degrees.
Okay, I wanted to pause it right there because this side view with half of it cut away is a really great view to not only see the big angle of the sacrum there, but also to see this big angle between L5, this right here is L5, lumbar 5, and the sacrum. So this big change in angle makes this a vulnerable joint. And in fact, there tends to be a lot of problem between L5 and sacrum, or L4, L5. And you might have like L5 slide forward. You might have a herniation there. So this is a vulnerable point. Does that bring up questions or comments? Okay, we'll move on.
Degrees to the horizontal. The tip of the coccyx points forward at about 40 degrees. So the pelvic surfaces of the sacrum and coccyx form a curve of a bit more than a quarter circle. The lower end of the sacrum is on a level with the top of the pubic symphysis. This big gap between the sacrum and the hip bone is called the sciatic notch. It's bridged by 2 major ligaments, as we'll see shortly. Now, we'll look at some details of the hip bone. This massively thick part of the hip bone is formed by the fusion of the ilium, the pubis, and the ischium. It's smooth on the inside and on the back. It's deeply indented on the outside by the socket of the hip joint, the acetabulum.
And this is a great view, I think, to see how deep that acetabular socket is. And I think it's also a great view to see what a great long border here we have of the sacrum. So this is that great border of the sacrum to really take your time with. And as we study the muscles of the glutes and the hips more specifically, you'll see how piriformis attaches this whole way. Questions so far?
This is the body of the ischium, which ends below in this impressive projection, the ischial tuberosity, which is what we sit on.
And you can see as he spins it around how big this ischial tuberosity is. And so when we talk about things like hamstrings, or originating or attaching to the ischial tuberosity, it's not a little tiny fixed point. So whether you use your, your knuckles or your elbows or your fists to really work those hamstring attachments, you want to make sure that you really explore, and you will literally feel how the muscles attach all the way around. And you're getting different muscles as you work your way around. So quite a big attachment there, a very critical one. And I'm going to call this out clinically right now, and we'll bring it up again later, that when people have low back pain issues or chronic low back issues, very oftentimes working the glutes, the hips, and the thighs, including the hamstrings, can be a really big part of the problem. And so when you hear about clients' low back pain, after first ruling out, contraindications, which we'll get to later, you might think mostly locally, right? Like what muscles are right there, but you very often want to work these glutes, hips, and thighs as well. And I'm calling it out now with the ischial tuberosity, because releasing there, I have found amazing results with that pelvic rotation, working right there. Questions, comments? We'll continue.
This sharp prominence is the ischial spine. The large hole.
And again, these are great for reference points and as we study different structures, but this ischial spine, as well as the sciatic notch and this obturator foramen, these are deep areas that we're not massaging.
Hole in the lower part of the hip bone is the obturator foramen.
And again, I'm just calling it out here. You'll see the word foramen a lot. It just means hole. So you'll see many terms that have foramen in it. So here we have this big hole, which will be covered mostly, by fascia ligaments.
In the living body, it's largely closed off by the obturator membrane. This is the body of the pubis. The part of the hip bone below the obturator foramen is the ischiopubic ramus. The two ischiopubic rami, meeting in front at the pubic symphysis, form the pubic arch. When seen from the side, the ischiopubic rami slope backward and downwards toward the ischial tuberosities. There are important differences in shape between the male pelvis and the female pelvis, which is adapted to the important requirements of childbirth. The female pelvic cavity is wider from side to side and deeper from front to back than the male. In addition, the angle of the female pubic arch is broader. When seen from below, the inferior pelvic aperture of the female is wider in all directions than that of the male.
Great.
Now that we've looked at the dry bones, we'll look at some major ligaments which are important in holding the sacrum and the hip bones together.
I'm just going to pause it there as he starts to, that's really weird with him in the bone. I'm going to pause it here, just preview to looking at the ligaments. Our next unit right after hot stone massage is myofascial release, which we're actually going to carry on to the rest of the program to continue to work with MFR. But as we start to really work with the fascia includes all the different types of connective tissue and all the different layers of connective tissue. And ligaments and tendons are a type of connective tissue. So when we get to actually looking at anatomy trains, the fascia and the releases that we're going to do include at times the actual tendons and ligaments. But, and this is an important but, and also a pun, in this area, as I've mentioned, pelvic instability with the sacroiliac joint is quite common. So I would not, sort of without knowing what you're doing, really focus on a release around the sacroiliac joint or destabilizing or loosening these particular ligaments. And as we just discussed with pregnancy massage, due to the effects of relaxin, this is the type of instability that we're particularly talking about when we're cautioning MFR during pregnancy, is particularly around these hip ligaments would be some of the most apt to be destabilized during pregnancy. And does that bring up any questions before we take a look at them? Okay, as we take a look at them, again, I highly recommend you're looking at your models as well, and even touching them. A lot of massage therapists are very kinesthetic learners, so you really kind of want to get this in your hands, which is why we also sculpt them.
The weight of the body is transmitted from the vertebral column to the hip bone at the sacroiliac joint. The sacroiliac joint is strengthened behind and in front by ligaments. The anterior sacroiliac ligament in front and the massive posterior sacroiliac ligament behind. In addition, the sacroiliac joint is strengthened by two major ligaments which pass from the sacrum to the ischium, the sacrotuberous and sacrospinous ligaments. Here's the sacrotuberous ligament. The sacrotuberous ligament arises here on the back of the sacrum. It passes laterally, downward, and slightly forward. It's inserted here on the ischial tuberosity. Now we'll add the sacrospinous ligament to the picture. Here it is. The sacrospinous ligament lies in front of the sacrotuberous ligament and medial to it. It goes from here on the edge of the sacrum to here on the ischial spine. These two ligaments divide the gap between the sacrum and the ischium into two openings, the greater sciatic foramen and the lesser sciatic foramen. Let's take a look at a complete pelvic specimen from behind and from below. The sacrotuberous ligaments behind and the ischiopubic rami in front form the boundaries of an opening beneath the pelvis that's called the inferior pelvic aperture. Seen from beneath, the opening looks like
we're going to stop there because this is where he starts to get into the details of the part of the pelvis that we're not going to be massaging and are not as directly related to massage. So let me get out of that video. Okay, so where we left off with this ligaments and somebody was already trying to picture where, how deep these are and spatial understanding. And I do just want to call out that while some of these areas like the ischial spine and so forth are pretty deep, that actually the sacrotuberous ligament, this one right here, is actually pretty massive and is palpable. So when you do deep tissue massage that's very specific, you can definitely palpate this one, and that can be part of some of your work. But again, you don't want to destabilize not knowing what you're doing, but that one is actually palpable. And then he didn't really get into this one yet, but I do want to call out these ilio-lumbar ligaments can actually be palpable as well. When we start to get really deep and focused on the transverse processes in the lumbar area, and we start to get into the really deep muscles of the low back, such as quadratus lumborum or QL work. So we'll talk about those again when we come back to it. So does that bring up any questions thus far? You can see, right, that there's this ligament, you know, on the sacrum itself. And we've talked many times about how it's great to work directly on the sacrum. Does anybody recall the muscle that actually is on the sacrum also? Of the multifidi and the rotatories, there is some multifidi actually on the sacrum, but there's beautiful fascia on the sacrum. And let me try to get to a good side view here. Sorry for the, I thought we had, this one doesn't show the spine as well. But with the side view and seeing the sacrum, we think about all that fascia and muscle right on top of the sacrum. And we were looking at those angles before and how you can get too much curve of the low back. This is really good fascia to release. And we're going to spend more time with that very soon in MFR. Does that bring up any questions? Okay, I'm going to pause here for a moment. Okay, so we definitely focus on the structures that we can massage and the ones that affect massage the most. So in this anterior view, you know, we're looking at a lot of ligaments that are too deep for us to palpate, but it's just good, I think, to have a visual understanding about every time there's a joint, there's really ligaments supporting it from every direction. So we've got ligaments supporting the anterior aspect of the sacroiliac joint. We have a ligament going all the way up the anterior aspect of the spine. This little relatively skinny ligament down here, the inguinal ligament, is actually palpable and is a demarcation or a separation point indicating that separation of the vulnerable endangerment zone of the femoral triangle. So while this is palpable, you know, we don't actually, you know, end up massaging it. Here's another view of that great, strong sacrotuberous ligament that is actually palpable. And then I'm going to wrap up with the ligaments that support around the femur, and then we'll take a lunch break. And I don't expect you to memorize the names of these three ligaments, but I just want you to take a look at how we have three strong ligaments that wrap around, curving around and wrapping around like a towel all the way around this neck and head of the femur. So we have a lot of great support, ligamentous support of that acetabulofemoral joint. So I don't need you to memorize the names of those, but it's just good to have like a visual understanding of them. And here's a great picture of that in a real body. And you can see those ligaments wrapping around. Does that bring up any questions? You guys are okay, so I'm going to read the questions of the poll out loud. What bony landmark do we sit on if we're using good posture? Because of this, it's named the sits bones. Hint, the hamstrings originate here. It's also a great place to massage, even for low back pain. Answers are coming in. The possible choices are pubic symphysis, ASIS, and ischial tuberosity. Number 2, what three bones fuse to make the os coxa or the hip bones? Choose all three that are correct. So you should choose 3 of the following: ilium, ischium, pubic bone, sacrum, and coccyx. Answers are rolling in. I will give you a few more minutes to do those, and I'm going to screen share today's